Good evening. Greetings from Team Digital Indian Medical Association. I am Dr. K. Agarwal, Honorary Secretary General IMA and President Heart Care Foundation of India. Welcome to our weekly show in which we have an expert and we talk about one subject. This is being brought to you in association with Library, our digital partner, and with eMediNexus, our webcast partner. Today's program is special because from today now we are starting a new concept that the first 3 o'clock to 3:30 we will focus a subject which will be for healthcare workers, for doctors, and the next 3:30 to 4 p.m. and it will be open to the public. So for the first time we are opening this webcast to the public and they can also ask questions. My phone number is 98110 90206. Note it down again, 98110 90206. We will also take some calls from the doctors and from the public if we find some time during our discussion. Today's function is special because we are inaugurating our public telecast with the Live Love Laugh Foundation, and we have with us the trustee of the Live Love Laugh Foundation, Dr. Shyam Bhat, who is a psychiatrist and who did his master's and his graduation from SIU School of Medicine in the US, and now he settled in Bangalore. The topic for today will be all about depression. And this has a special focus because this foundation was founded by none other than Deepika Padukone, our film actress, who is trying to devote her life in creating awareness about mental health. The theme of this campaign is more than just sad. That means we are talking about creating awareness about depression, its early diagnosis, its incidence, and everything together. So let's go ahead with our program. And again, I'm giving my number 98110 90206. If you have specific questions during the webcast, you can ask us. And this webcast, once it's live, and later on it will be available on our website, on the Library website, on eMediNexus website, on Heart Care Foundation of India website, on Talking Point Communications, who is our event manager for this show, their website, in Indian Medical Association website, and also it will be available on the website of the Live Love Love Foundation. Welcome to our show.
Thank you, sir. Thank you. It's a pleasure.
So my first thing which comes is, and that's a good news for you. And the good news is the Medical Council of India has already passed, which is now likely to get amended. And according to the new Medical Council of India rules and regulations under the MCI ethics, they said out of 30 credit hours, 10% of the credit hours have to be in mental health.
That's very good.
So the Medical Council of India is mandating that the medical curriculum, medical education, PG education, all GPs everywhere, when we submit our credit hours, that means minimum requirement, it has to be 10%. Indian Medical Association has also passed a resolution, and they said in every CME, in every lecture, one slide has to be focused on the mental health.
I see.
That means whether you have asthma, whatever disease you talk about as a CME,
Okay.
well, the last slide has to talk about mental health. Related to a comorbid condition, whatever is related.
Got it.
Say asthma and anxiety, asthma and depression,
Sure.
how mental health. So therefore, Medical Council of India has already cleared this amendment. It's now with the government to implement it. So therefore, Indian Medical Association already has decided, and that's the reason we are here.
That's great.
So in every of our webcasts also,
I see.
we try to focus some things on that.
I see.
Now before I go to actual depression, I will go back that depression can't be a new thing. Okay? We know Indians are more prone to get depression. And if Indians are more prone to get depression should have been an age-old phenomenon.
Not necessarily.
No,
Not
let me
the-
explain. If it is an age-old phenomena,
Yeah.
my mythology has to mention about it.
Yes, that is true.
And if my mythology has to mention about it, then Bhagavad Gita is the first textbook of cognitive behavior therapy.
Yes.
And if you see Arjun, in the very first chapter, he says, मेरे पैर लड़खड़ा रहे हैं, मेरे हाथ से धनुष छूट रहा है, मेरे रोंगटे खड़े हो रहे हैं, मुझे कुछ समझ में नहीं आ रहा कि मैं क्या करूं. Acute panic reaction, depression with anxiety overlay. And then Krishna, what did Krishna do? In the first, Krishna said, I will take your 18 sessions, 18 chapters. In the first chapter, in the first Gita chapter, Krishna just listens to Arjun. Good, patient, history taking. He doesn't speak a word. Second counseling session of Krishna to Arjun is the longest session with more than 772 shloks, 76 shloks. Longest session till Arjun is confused. Then from 3rd to 17th, he explains with everything reasoning. डराता है विराट स्वरूप दिखा के पुचकारता है कि डोंट वरी व्हेनेवर यू फाइंड डिफिकल्टी आई एम विद यू एंड देन इन 18th he revises and then only Sanjay tells Dhritarashtra जहाँ कृष्ण जैसे टीचर होंगे अर्जुन जैसे स्टूडेंट होंगे वह जीत धर्म की होगी. So therefore at that time there were no counselors, there were no psychiatrists, there were no SSRIs. So the counseling was available.
Absolutely.
And if we see all our Upanishads, all our Gita, Bhagavad Gita, all Upanishads and all Purans, basically they all talk about counseling. They give messages, they talk about counseling, prayer, meditation, relaxation,
Absolutely.
everything was related to, that means somewhere during that era also,
Yes.
without naming his depression,
Yes.
they were aware
Absolutely.
that Indians are more prone to get depression. When we say, if that's so, how common is it today? How common it is today?
So I think your point is very, very valid. In fact, I'll come back to that, but it's very valid that we have, as a culture, a long history of trying to understand life, trying to understand what makes us really happy, trying to understand the true nature of the self. That is what the Upanishads are about. And when Krishna told Arjuna to be a karma yogi, that was probably the single best advice ever given by any therapist or any person, and an advice that even today will be echoed all over the world, including in our therapy offices. Now, one thing though, I think that while we were a rich culture and we thought a lot about existential issues and life and so on, if you look at data, there is probably an increase in the prevalence of depression in India today.
Diagnosis or the incidences?
We could argue that. Arguably, maybe, as you said, is it that we are diagnosing more, is it actually increasing? But there are some interesting studies. If you look at urban India versus rural India, leaving aside people like the poor farmers who are afflicted by, other than that population, if you look at the rural versus urban, there is no doubt that moving from rural communities to urban communities will increase the prevalence of depression. That moving from our socialist, collectivist, pre-capitalist culture to the new Western individualistic culture increases depression. So I think the data and anecdotal reports suggest, no, we are getting more depression as we change our lifestyle. There's a very interesting study done by a physician from University of Chicago. Her name is Joan Chiao. And in 2009, she published a study which is remarkable. What she did was, she looked at the entire world and said, let me see the prevalence of the serotonin transporter gene polymorphism, which is on chromosome 17. And that there are two forms of that gene. One is the long form and the short form. And the short allele has been linked with much higher rates of depression. If you have stress and one person has the short form of the gene and the long form, the short form person is much more likely to have depression. What she found was very interesting. What she found was where cultures are collectivist like India, China, Latin America, they have higher rates of this depression gene. Where cultures are individualistic like Europe and America, they have lower rates of the gene. So her hypothesis was this, that this gene makes us more sensitive to criticism as a population, more sensitive to disapproval as a population, and therefore our culture co-evolved with the genetics to protect us from all disapproval. We became a collectivist society. We as a society want to get connected with our community, unlike the Americans. Now what we have to understand, I think, as doctors, is that this is the case, that our culture was protecting us from the harmful effects of our genetics. When we change our culture as we are doing today, what is going to happen? So if 50% of our population has the short form of the certain transport gene, as we change our culture, we may have rates as high as 50%. Today the data says anywhere from 30 to potentially 40% of people, at least in urban India, have clinically diagnosable depression, dysthymia or anxiety. the most common psychiatric conditions. So it
That
is an
we are talking about is like an epidemic now.
it is definitely an epidemic. There's no doubt.
And then we talk about at any given time or during their lifetime, they're likely to suffer one of them.
If you look at incidence of major depressive episode, it is 40%. If you look at lifetime prevalence as such, the rates are 15 to 20%. So, but there's no doubt we are in the probably the beginning stages of an epidemic. It's going to get even worse. It's not going to get
more
better.
and more people living alone.
More
This is
people
going
living
to be
alone.
disaster.
Also, sir, if you consider the youth of our population, that 70% is under the age of 35, they are the ones who are going through the most change in this country. And as you correctly said, we have, as a culture, we got a lot of insight and support from our scriptures, from elders and so on. Today, that's not as common. So what is happening to millions of young people? They're getting more confused. If you want evidence, look at divorce rates, they're gone up. Look at suicide rates, they've gone up. We have one of the highest suicide rates in the world in the 15 to 29 age group. In a Lancet study a few years ago, they said our suicide rates in 15 to 29 is 10 times higher than the United States. And I think that's underreported. As you know, suicide in our country is still a big stigma and shame, and I don't think we get all the suicide rates.
So when we were studying in cardiovascular disease,
Right.
we were trying to find out, because new epidemics is CAD, diabetes, depression.
Yes.
Then we have new epidemic is atrial fibrillation. Then ultimately they all came out to be two things, either metabolic syndrome or hypovitaminosis D. Okay, by culture, if you see, our culture says that once in a year for 30 continuous days, you need to do Shahi Snan. Shahi Snan. And in Shahi Snan, you need to sit in the sun, take a sun bath,
Correct.
and take anything food which is high calcium.
Correct.
So therefore, our ancestors told us that you need to take vitamin D.
Correct.
Okay. And the second thing they told us was to refrain from eating refined carbs.
Correct.
So therefore, they said once in a week, don't take carbs. Once in a month, don't take carbs extra for a day. And then twice in a year for 9 days is during Navaratri, don't eat carbs.
Correct.
And if you take carb every day, you end up into metabolic syndrome, hyperinsulinemia, and insulin resistance.
Correct.
Are both of them related to depression?
Metabolic
Because this
syndrome.
is metabolic syndrome and hypovitaminosis days. If yes, then the whole thing gets easily that the basic paradigm shift in our country is that we are becoming more and more vitamin D deficient, and we are getting more and more
Depressed. I think
not depressed, hyperinsulinemia. Are
hyperinsulinemia.
both of them linked?
I think so. See, my background is, as you know, I did internal medicine and psychiatry, so I've always seen the mind-body connection. If you look at the multiple, first of all, I think we have to understand that depression is a multifactorial condition. Many Indians think कि अगर depression हो तो there must be some एक reason होगा कि because of this you got depression. As you know, as a doctor, it's multifactorial, including genetic predisposition, diet, vitamin D deficiency, pollution, lack of exercise, lack of social networks. So if you look at natural treatment of depression, consistently they found that exercise, replacing vitamin D, and good social connections, and the right diet, as you correctly said, will actually treat a lot of depression and prevent a lot of depression. If you look at comorbidity, I think we underestimate it. If you look at, so for example, look at the connection between post-MI mortality and depression. You know, post-MI mortality is about 2.5 times in those with depression because, as you know, depression reduces heart rate variability, and there's a parasympathetic drive is decreased. You have reduced heart rate variability, and the death from ventricular fibrillation and arrhythmias are 2.5 times higher in those with depression. So depression affects platelet aggregability, it affects rhythms. It is a mind-body condition, and therefore the approach of that is why we want the physicians to be involved. As long as physicians think depression is something in the mind and nothing to do with the body, then I don't think we, have completely.
So the first lesson is that depression is common,
Yes.
and the second is depression is a disease.
Correct. It's absolutely.
Then you and me need to fight.
Absolutely.
Because the IRDA and the insurance company says it is not a disease. So there is a conflict.
Unfortunately.
And when they say it is not a disease, all the GPs, the message is going in a conflict. Is it a disease or not?
Correct.
So therefore they say it is a disease, but I need to know it to write.
Correct.
That means I can't write it as a prescription, I cannot prescribe, because if I prescribe or write it as a disease, then the Medicare will not pass the claim.
That's very unfortunate.
So one message is very clear is that depression is common, and second is depression is a treatable, chronic, manageable disease. Is it curable?
Yeah, I believe it is, and this is where I think we must differ from the West. In the West, if you look at depression, a lot of patients will take pharmacological treatment indefinitely. They become, so to speak, institutionalized. They have to keep going to their psychiatrist and therapist. I spent 10 years there. I realized that one big problem there is that they have not integrated talk therapy, yoga, meditation, lifestyle. You cannot treat depression like it is an illness, but I guess it's an illness like diabetes. So we cannot just give insulin. You have to, as you know, do all the other things, diet, lifestyle. So depression is pretty much like that. If a person pays attention to every element, mind through psychotherapy, brain through medicine if necessary, body through correcting metabolic abnormalities, getting a better diet, better lifestyle, and higher order spiritual thinking about what the meaning of life is. If they do all of this, it is not just curable, I believe it's transformative.
So it is important, along with the depression, to go into a parasympathetic lifestyle.
Correct.
We need a parasympathetic breathing, which is pranayama, deeper and slower breathing.
Absolutely.
We need some parasympathetic asanas,
Absolutely.
which stimulate our endocrine
Parasympathetic
system.
Absolutely.
And then we need to live a complete parasympathetic exercise system, which are postures. And you call them as asanas. In this. Now, and one more interesting thing is that when you talk about Bhoot, Pret and Pishach, and for me, Bhoot, Pret and Pishach in modern medicine basically means that you're getting thoughts of something. Somebody is unfinished work is trying to disturb you, and this happens in REM sleep. So during REM sleep you get up and then you get dreams, and to reduce REM sleep you have SSRI. SSRI reduces the REM sleep, therefore it is effective in these disorders. Now when we are looking about Hanuman Chalisa, and if you read Hanuman Chalisa, they talk about Bhoot Pret Nikat nahi aave, Mahavir jab naam sunave. So when you go back into Hanuman Chalisa and when you recite the chopai of Hanuman Chalisa, all 4 chopai in one breath. So what will happen is when you speak the whole Hanuman Chalisa multiplied, divided by 4, and each 4 of them in one breath, you reduce respiratory rate.
Correct, exactly.
When you reduce respiratory rate,
Parasympathetic drive.
you shift to parasympathetic breathing. Sympathetic drive goes down, and that automatically, if you practice it every day, you will reduce your REM sleep.
Right.
So therefore, it is scientifically possible that if you train your patients for parasympathetic breathing,
Absolutely.
they will be able to get natural SSRIs.
Absolutely.
And that doesn't mean that they will not require SSRI, but the dose may reduce.
Absolutely right.
And therefore, it may be curable over a period of time. They may be able to come back and reduce their SSRI dose.
100%. I think that is exactly what the approach we want in our country. That we cannot just rely on SSRI treatment. We need to use the.
Let me see if there is a phone for us. Yes, hello. Yes, बोलिए. हाँ बताइए, सवाल पूछिए, बोलिए. हाँ जी, मैंने डिप्रेशन की दवा खा लिया था. हाँ, हमारी याददाश्त गड़बड़ हो गई.
कौन सा मेडिसिन?
कौन सा मेडिसिन खाया था आपने? ओलियम भी ओलेंजापिन दिया था. और क्या खाया था? XET. Anyway, ओलेंजापिन उन्होंने खाया था, तो वो डिप्रेशन नहीं रहा होगा.
Must be something.
Must be different type of a condition. ये जो ओलेंजापिन जो आपको दी गई है, ये डिप्रेशन में नहीं दी जाती. ये नहीं, आप अपने डॉक्टर को दिखाइए, क्योंकि ये डिप्रेशन नहीं लग रहा. तो ये अपने डॉक्टर से दिखाइए कि वो डायग्नोसिस उन्होंने क्या किया था, क्योंकि हो सकता है ओलेंजापिन हम लोग डिप्रेशन में नहीं देते, वहाँ पे मूड एलिवेटर देते हैं. तो ओलेंजापिन अगर आपको दिया है तो हो सकता है आपको कोई साइकोलॉजिकल बीमारी उन्होंने बताई हो, उसका तो फिर पूरा अच्छे से इलाज कराना पड़ता है. थैंक यू.
So, olanzapine, sometimes we use atypical antipsychotics as augmentation, but if that's the only medicine
that is
taking...
specifically in OCD you use olanzapine as an add-on to SSRI, but not...
Usually not for major depressive disorder.
Not
he
for
may have
depression.
some other condition.
So before I go back for the doctors,
Sure.
let me come back. How will the GP diagnose depression?
Yes.
Okay, before I go to the screening for depression, first of all, he has to diagnose that this is real versus unreal, so that he can take away schizophrenia disorders, major psychotic disorder.
Correct.
Is any other screening method for him?
Well, ideally, and I know GPs are hard pressed for time, but ideally in every depression case, you want to rule out bipolar disorder.
No, in the first, before going into depression,
yes.
I first want to rule out schizophrenia.
Yes.
I want to rule out major psychiatric disorders.
Correct.
Any one screening method. Question. One screening question.
No, not one say. It depends on what you need. You need to rule out psychotic disorder, which is a little more subtle and harder to do. So what we often say is, rather than the GP getting into that, you diagnose depression. Keep the sensitivity high, specificity low. rather than being, and in that way, because 90% of the cases will be neurotic depression or anxiety rather than psychotic illnesses. Usually a severe mental illness is much more obvious, meaning the person will be withdrawn, psychotic, thought disorder, not speaking in a logical.
Not in a real world.
Not
so
in
if you find if you are
if someone is delusional.
Suppose you are in a real world.
Suppose you're not. If you have a delusional disorder, meaning you have false beliefs, that is something that a psychiatrist must see.
He must see. So therefore, anything if there are any finding that he is not with the reality, refer.
Correct. If reality testing, as we say, is impaired, you refer.
Second we come back is intellectual functions.
Correct.
So the first to go will be immediate memory. So if the person has no minimal cognitive impairment, or if his intellectual functions are normal,
right.
And then go back to in normalcy. Now you are looking for is it normal, depression or anxiety?
Correct.
What is that PHQ2 question?
So the PHQ2 is a good screening
what is
question.
P, what is H, what is Q?
Patient health questionnaire 2, PHQ2. There's a PHQ9, which is a patient health questionnaire 9, which is a great depression screening, but takes a little longer. So research suggests that 2 questions will give you a sensitivity and sensitivity of about 89%, specificity about 65%, but that's okay as a screening test. And the 2 questions are, number 1, have you felt depressed, sad or low for most of the time in the last 1 month? First question. Second question,
is it more than 15 days?
Most of the time means
throughout?
Any of us.
That means there is a window period of 1 month.
1 month. When you think of the last month, okay, most of the time were you feeling down or not? Simple. First question. Second question, for most of that month, did you find less interest in doing your usual activities, what you enjoyed doing before? If the patient says yes to both those questions, a very strong likelihood they have an affective disorder. In which case,
it has to be more than 1 month.
It has to be.
Somebody says 7 days.
2 weeks is the DSM criteria, but for the screening we take 1 month just to to make it more accurate, to sort of change the threshold. 2 weeks is DSM criteria, but that's a difference. You have to ask some more symptoms, for example, sleep, appetite, concentration.
That will come in PHQ9.
That will come in PHQ9. So PHQ9 takes the DSM criteria, puts it as a self-rating questionnaire. You can find it free online. It's public domain. Patient fills it out. There's an answer key which tells you how to score it.
No, here I need a consensus between IMA and the Psychiatric Association.
Okay.
Unless you're going to make PHQ9 billable, nobody will work on it. So therefore, PHQ2, everybody should be told, you do PHQ2, and if there is a signs of depression, then PHQ9 should be a test like hemoglobin. It can't be a screening. It has to be like, therefore it is billable.
Fair enough.
That means psychiatrists and GPs need to sit together and say, okay, if you spend time on PHQ10, it's a test.
Correct.
That will be done by anybody.
Correct.
Because you are interpreting something. Let it be chargeable, 100 rupees, 200 rupees, 300 rupees, whatever it is.
Sure.
Therefore, PHQ9 cannot be a screening test. It has to be a test.
Okay.
Every screening test also. So what will happen with that is, now in the module where you are giving a GP or a physician, he is making an effort, he is spending time, he is diagnosing, and therefore he is entitled to a charge.
I think so.
Then what will happen is, the program will take up. If you are going to tell everybody that do PHQ2 and then do PHQ9, he says, why should I waste my time? In this period, I would have seen 3 more patients.
No, I think, sir, absolutely cognitive work has to be reimbursed. Otherwise, why would, it's time and effort. I think absolutely right. This is also a self-rating question. The patient could take it themselves also.
But then,
if they want.
Even if he is doing a self-rating, he will come back to the doctor. Doctor will have to verify that. Once the doctor is diagnosing,
no, I think
either he is treating himself or referring.
Correct.
These are why these programs are failing.
Right.
These programs are failing because everybody says screening should be free.
Correct.
Why should screening be free?
I don't think. I think that's perfectly legitimate. Absolutely. What you're saying.
So that's the first is that depression is common. Mental health problems are there. Second is we need to fight with the medical claim department that it's a chronic, manageable, treatable.
It's a curable condition even.
Curable.
Yes.
In some cases, it is a curable disease. And third is screening is simple.
Exactly.
And for when you suspect, then you have a test available where you can diagnose and you can even bill. Next thing which comes is, hello. So another thing which comes is that whenever we have a suspecting depression or a mental health problem, we need to rule out organic disease.
Correct, absolutely.
Because if we don't rule out organic disease, we may be in trouble.
Absolutely.
How will a GP do it? Hello? हाँ जी बोलिए. बोलिए. अच्छा, मैं करता हूँ, थोड़ी देर में करता हूँ। अच्छा, इनका जो सवाल है ये केरला से पूछ रही हैं, इनका भी वही सवाल है
क्या
कि सेकेंड ऑर्गेनिक कैसे रूल आउट करें।
अच्छा, so good question. So first thing, I think in the Indian context, it's important for everyone. Everyone knows this. GPs know this, but I just want to reiterate that, as you know, in our country, many times depression and anxiety present with somatic symptoms. So again, they've done research saying, look at collectivist societies, Latin America, China, India versus West. More somatic symptoms in collectivist societies, more mental
एक और
symptoms
सवाल है,
in the Western
एक और
society.
सवाल ले लेता हूँ मैं। हाँ, हेलो हेलो हेलो, इनका भी सवाल B12 से रिलेटेड है।
Achha. So first thing to remember is that many times depression and anxiety in our country will present with physical problems. Many, as you know, will go from doctor to doctor saying chest pain hai, ki there was abdominal pain, diarrhea, constipation, fatigue, headache, back pain. All of this can be actually because of depression. Now, so first thing is that the GP, depending on the physical symptoms, should do the necessarily rule out tests depending on the symptoms. Secondly, all patients with depression, anxiety symptoms should be screened for common things like thyroid, TSH should be done, vitamin D, vitamin B12 should be looked at, because both of these deficiencies can cause or worsen depression. Those are the basic things.
Screening for alcohol.
Yes, absolutely. If the history determines, you definitely want to check for not just alcohol but other substances also, because as you know, in urban India now, cocaine, for example, has become more common. Alcohol is a big problem, comorbidity. So screening for substance abuse is also very important. These are the main things. So it's actually simple. Organic, either if there are no symptoms, no other symptoms, you do basic thyroid, vitamin D, vitamin
So
B12,
TSH,
vitamin B12, vitamin D, bus. Then guided by symptoms.
and if they are, treat them first simultaneously.
It's simultaneously. Unless the thyroid there's a lot of hypothyroidism that explains the depression. For example, mild vitamin D deficiency, we won't just give the vitamin D, we'll also treat the depression because it's one of the cofactors.
Okay, so then we have suspected a patient with depression, and we have seen the thyroid is normal, B12 is normal, vitamin D is normal. Even then, whether it is normal or not, we give them a supplement of vitamin D.
Correct.
Now the next question which comes is, when to treat? That means, how do I treat myself?
Yes.
When do I refer?
Great question. There are many options for treatment. In mild depression, by mild I mean a PHQ 9 score of under 10. This will be there on your PHQ 9 key anyway. But anyway, mild depression, if you have mild depression, the person might benefit just from lifestyle modification and counseling without the need for medicine. In moderate depression, if the person is willing to take a medicine, studies suggest that medicine will add value and increase the response and decrease relapse rates. So at that point, I would recommend the GP start a SSRI medicine. Usually we say S-citalopram is one of the newer forms, easy to use.
And now we will open it to the public also. This session now, for the next half an hour, will also be open to the public.
So you start on an SSRI, so half the dose, usually 5 milligrams of S-citalopram, wait for 2 weeks and increase to 10 mg.
So here the message is that ask your doctor, because now up till now we were talking about the doctors. Now the public is also joining in, and we are talking about depression. Depression is common, and depression means that if you suspect that in the last 1 month, all the time you were feeling depressed or you were feeling lack of interest, then go to your doctor. And your doctor may ask you a few tests like a thyroid test. Your doctor may ask you to get a B12 test done, a vitamin D test done, and he may like to see you whether your depression is mild, moderate or severe. And this is possible. A doctor may treat you on a mild depression with mood elevators. Remember, depression is now curable, chronic manageable, it's no more a stigma. And a doctor may do a multiple sessions of counseling, which we will spend some time now. And then your doctor may put you on a mood elevator. Remember, these drugs are mood elevators. So it is not pagalpan ki dawa. It's not a medicine for madness. Depression is not madness. Depression is not what is shown in the movies, like they are trying to people. All those people which are shown in movies are not actually depressed. They are schizophrenic. And that is a rare phenomena as far as mental health is concerned. The most common is depression. So therefore, all those people who are watching here, and if you have any question regarding depression, that means in the last 1 month, if you feel that you have a lack of interest in your activities most of the time, ring up 98110 90206 and Dr. Shyam Bhat, our expert today, who is a psychiatrist and trustee of the Live Love Love Foundation. He's going to answer your queries. Let's go back to the mild depression. Then we say counseling, lifestyle management. And in lifestyle, exercise,
Diet.
diet, exercise.
Exercise at least 3 to 5 times a week of aerobic activity,
Aerobic
which elevates
activity.
your heart
So
rate
it can
for 30 minutes at a time.
Okay, like a cardiovascular exercise.
Cardiovascular exercise.
Like it can be a dance.
Yes.
It can be a dance,
Walking,
aerobic
swimming.
dance, or it can be a classical dance, it can be swimming, it can be cycling or
Walking,
anything.
yes.
That's one. So one is exercise. It increases, reduces insulin resistance and it helps you. That's one. Two, in diet. In diet what?
Diet, as you were saying, avoid processed carbohydrates.
Refined carbs.
Avoid any high glycemic index foods. You must avoid.
Whichever diet you do it to
For
prevent
metabolic
blood
syndrome?
pressure, metabolic
Correct.
syndrome,
Exactly.
diabetes
You got
or
it.
heart, you get it done.
Exactly.
That's the second.
Exactly.
Third, make sure that you get enough vitamin D, sunlight exposure,
Exactly.
which in any way reduces depression,
Correct.
episodes of depression.
Absolutely.
It reverses serotonin versus melatonin ratio. And second is sunlight, or you take vitamin D supplements.
Right.
That's the second thing.
Right.
Third thing, the next thing comes is
The next thing is
parasympathetic
next thing is relaxation exercises.
relaxation exercises. In relaxation exercises, can they learn?
Pranayam, yoga.
Can they learn progressive muscular relaxation?
They can. Progress.
So
Our
PMR.
own yoga nidra is like PMR.
Yes, yoga nidra, shavasana,
Shavasana.
or talk to a doctor for progressive muscular relaxation.
Yes.
In progressive muscular relaxation is a type of a yoga nidra. In every religion it is being taught, where you gradually concentrate and let your organs relax. You are basically watching your organs relax. So that's progressive muscular relaxation.
Meditation like
In
Vipassana.
meditation is a vipassana or a mantra meditation.
Correct.
Meditation is the concentrating on the object of concentration and giving preference to object of concentration over the thoughts. Learn from any way, do it. Parasympathetic breathing, which is slower and deeper breathing, pranayama, it will help you.
Absolutely.
Okay, so a yogic lifestyle, which in allopathic science we call them as a parasympathetic lifestyle. So diet comes in, then exercise comes in, then parasympathetic lifestyle comes in. Anything else in lifestyle? No alcohol?
Reducing, not using substances. Alcohol, if you're using, use very occasionally.
And remember that the
Smoking.
relaxing dose is 18 ml only. Anything more than that, alcohol if you take over excess alcohol, it may give you depression.
Smoking, or people who are depressed smoke more than the general public, and
They need to be counseled.
They need to be counseled.
Substance
And,
abuse.
Substance abuse. Many people with depression may use substances.
Marijuana and other things.
Marijuana, cocaine. These are a lot of dangerous substances that obviously one has to avoid. Then having good social ties. This is actually very protective.
Seva, satsang, simran.
Yeah, absolutely.
That's what Sikhism talks about it. Seva means helping others,
Exactly.
communicating to people.
Correct.
Satsang means
Sitting in the company.
sitting
of
with the
truth.
company
Yeah.
of people who are good.
Yes.
And simran is meditation.
Yeah, perfect. The very, very
And that's what.
that is what our
So become a good
cultures-
Sikh.
All religions. I
All
think all
religions.
religions is about the same balance,
Absolutely.
love,
And
connection.
if you do that and then meet people,
And then control your own desire and aspiration, because that's become a big part in our
so
society.
that's what CBT is. That's what counseling is.
Part of it, yeah.
Part of it. So in counseling, you have cognitive behavior. So you change your
Many types of counseling. One
Okay.
form of counseling is CBT, which is cognitive behavioral therapy, which is a very structured form of therapy where we look at thoughts and behavior and how to change a negative thought into a balanced thought and how to make a link between your thought and your behavior. Very good therapy, but often no one practices pure CBT. We also get into childhood, we get into phase of life, we get into what is your deep unconscious conflicts in life, what is your real purpose.
You see one more. Yes. बोलिए ये कह रहे हैं कि मेरे पेट से भी क्या डिप्रेशन से कोई ताल्लुकात है?
Two ways. One is that it's a very common symptom in India, especially for people to have some kind of abdominal symptom for depression, with abdominal pain, irritable bowel syndrome kind of symptoms, or abdominal tension. If our organic etiology has been ruled out, most likely it is a depression.
If I go back to my Vedic science,
And as you know, serotonin is more in the gut than in the brain. There is a very deep gut-brain connection.
feeling.
Gut feeling.
That's the reason you say
Exactly,
gut
we say
feeling.
gut feeling, because that is your neurohormones come
and
from
that's the way you say, oh shit, whenever you
Absolutely.
whenever you have something problem, oh shit. Because
Absolutely.
you all
If you're
talk
nervous,
about
your sphincters are open.
and if you go back to the mythology, it talks about that the sacral chakra is linked with fear.
Yes.
And the gonadal chakra is related to attachment, and the celiac plexus is linked to doubt.
Correct.
So therefore,
Absolutely true.
wherever you are in doubt, you
Absolutely.
have GI movements.
Absolutely
So they all are linked
Absolutely true.
with the whole thing. Again, going back to the counseling, counseling can be
Many forms of counseling.
many counseling. So for my people to understand,
Right.
let's have some basic principles of counseling.
Fine.
One is it may not be cheap.
Correct.
Good counselors may charge more money.
Correct.
Two is it requires multiple sessions.
Correct.
How many? 12, 13, 16, 18? In Bhagavad Gita, Krishna took 18 sessions.
He was a very good therapist and he needed 18 sessions, so you can imagine how many sessions
How
it
many
takes.
sessions
It
there?
really depends on the case. It is like asking a gym, how long will it take to build my body?
So,
Depends on
so
what kind
therefore
of body
people
you
need to know that multiple sessions are required.
Definitely multiple sessions.
They are
Nothing
not
less than-
free.
They are not free.
They need to be paid.
They are expensive.
Because they are expensive. That's the second thing about sessions. And third thing is they vary the type of counseling they're giving you. That means, and third thing is that privacy and confidentiality is maintained.
Absolutely.
Because otherwise nobody will go.
Another point, as I think we were talking earlier, is that there's a huge variability in the kind of therapy, in the kind of counselor. See, because in our country, as you're saying, we don't have standardized rules and practice guidelines. A counselor can be a social worker, can be a psychologist, can be a psychiatrist, or can be a lay person. And each person, and actually, I want to emphasize the fact that psychotherapy is like surgery. It is not a trivial thing. Many times I've seen people being hurt by bad therapy. If a really bad therapist is there who is not even professional, they can exploit the patient. Remember, when a person comes to
Therefore, I say privacy, confidentiality, ethics,
Ethics
morality.
is very important.
They're very important
Very
because you are exposed. Unless you
Very vulnerable,
expose,
no?
unless
Yeah.
you expose yourself, your secrets,
That's right.
Other person you will not be able to
Correct.
get a help. And if you don't have a confidence,
And if that person doesn't have the ethical thing to treat this with due respect, because otherwise when you open up to someone, you become almost in a way vulnerable. And if that person misleads you, you can get into a lot of trouble. It is not like talking to a friend, that I want to tell you. See, many people say, why do I need a therapist? I have a friend, I can talk to a friend. A friend is emotionally involved. A friend is not objective. A friend does not understand how to understand your unconscious mind. And another problem is people say, yeah, why do I need counseling? I know everything. I'm a smart guy. I'm intelligent. What's a counselor going to tell me that I don't already know? And I tell them, look, even as a psychiatrist, if I have an issue, I have to talk to a counselor. A mind cannot examine itself no matter how intelligent we are. The mind will always deceive our own mind. And that is why we need a trained professional to point out our
what
own
about self-therapies, writing, free writing?
Very helpful, but
Because if you
as a
see,
supplement.
if you see our mythology, they used to teach us talk to the people ka ped,
correct,
talk to God,
correct,
do self-writing of
correct,
books,
correct.
then talk to your dog or a cat or anybody. I'm not talking about materialistic
I
talking
understand.
to your friends.
Right, right.
Even they used to say open out, open out, open out. Don't
Correct.
keep it to yourself.
Correct. I do.
And what about narration exposure therapy?
Say that again?
Narration
Yeah,
exposure
very
therapy.
very useful to reduce PTSD. So, for
PTSD.
example, when you have trauma, to talk about it, to narrate it. See, the most problems happen in trauma when we lock it inside. It's very interesting, people, if you observe a deer in the jungle and it is relaxed, drinking water, what happens? Tiger comes, it immediately starts running, this, that. And they have observed it. Even after a tiger attacks the deer and then the whole incident goes away, the deer will, 1 or 2 minutes, it will shudder. Then it will get back to its normal thing. As humans, we take stress, we don't know we are stressed, we don't express it, it just stays in our body. So we have to learn from how the natural world deals with it. You stress, you experience it, relieve it, let it
Now,
go.
if I just have to do if I just try to correlate it, in our Chautha and Tervi, if somebody dies, so you make that person identifiable from a distance, white clothes, take the hairs out.
Right.
So from distance you know that he needs therapy. Then you do 1 hour of Bhatak every day. And in that Bhatak, you don't do a public hearing, you don't talk, every person has to come and you need to narrate what happened. So you start narrating, then 100%, then 90%, 80%, 70%. In the second lapse you say, Jo Bhagwan ki marji, and the last you say, you don't even spray and you are detox. And you do it every day for 4 days or for 13 days and you detox. This is a classical example of Vedic narration exposure therapy.
Yeah, absolutely. Absolutely.
So
I think it goes beyond that, right? Because if you look into Vedanta, it will tell you that all your narratives are Maya anyway. There is no, all narratives are only a construct.
Absolutely.
And you're right, as psychiatrists, I have to see if your narrative is hurting you, let us try to find another narrative. Because as you know, my memory, I've got million events, you've got million events that have happened to me. So every person, when we are depressed, we connect all the bad events and we have a sad story. Suppose we change the story, we have a very different feeling about the same.
So it is possible that mild depression you may be able to get a cure without
Without medicine.
medicines,
Yes, absolutely.
and you can have a prolonged or permanent remission.
Absolutely.
If it is a moderate, the doctor may give you a mild
Assist.
mood elevator.
Yeah.
The commonest is SSRI, the commonest is escitalopram, but let the doctor decide. And up to a dose, even a GP can manage.
Oh yeah, absolutely.
But if he finds that few months patient is not responding, patient has a suicidal ideation, or he has attempted suicide, immediately a medical legal emergency and refer. And if he finds any evidence of a severe depression,
Refer
these are the patients who needs to be referred,
to psychiatrist.
either referred or take them to a, if you want to treat them, then be under a psychiatrist.
Correct.
So that you co-manage with him.
Absolutely.
You co-manage with him. And the message has to go to the public very clearly is that depression is controllable.
Nothing to be ashamed about. It's not a weakness. It is not a moral failing. It is a condition, and you should not feel bad that you have it or ashamed to have it. Just take care of it like you would anything else.
And it is a chemical locha.
It is a chemical locha.
What that movie?
Munna Bhai, I think.
Munna Bhai. It's a chemical locha. It's not a.
It's not a personal.
It's not a.
failing.
And then if you do that chemical imbalance, so if you do the balance, you should be able to. Now again, I come back to serotonin versus melatonin. Let me spend some time. What are the natural other ways of increasing serotonin apart from SSRI?
I think first thing we must understand that the serotonin hypothesis is also a bit of a shortcut. I mean, oversimplification of what happens in the brain, because now they've done there are multiple neurotransmitters involved. How do I get a better neurochemical balance in the brain? I think all the activities we've talked about, they've done studies saying that CSF metabolites of serotonin actually increase. There's an interesting study from Japan. They looked at Shirodhara, effect of Shirodhara on CSF serotonin. Very good results. So there are multiple ways to the same endpoint. Medicine is one way we boost serotonin.
Now Shirodhara is a technique which is available in Ayurveda. Shiro means sar, dhara means in the flow of. Shirodhara is like a way of demonstrating how do you do meditation. Meditation is also a continuous dhara of flow of thoughts. Here you are using oil or water or lassi or milk, and you continuously pour over your third eye area, which is center of the head, continuously and in a moving direction for the next 15, 20, 30, 40 minutes. And it is supposed to be changing your biochemistry or chemical composition in the body, and it helps. And therefore, when you go to a panchkam in Ayurveda, and panchkam is 5 different types of kriya, which includes balancing Bhat, Pitta and Kapha, which is movement, metabolism and structure. As a part of panchkam, now most of the people as a part of abhyang are adding Shirodhara into it. And Shirodhara has been a therapy recommended by an Ayurvedic doctor specifically for acute anxiety, panic reaction and anxiety overlaying the underlying depression. So therefore, if somebody advises you, my colleague, if allopathic doctors are listening, if somebody advises you Shirodhara, don't say hoax hai, don't say Ayurveda mein kuch nahi hai. And they can be combined and they may be able to help you in reducing your SSRI dose.
It works very well. I mean, see, there are some new forms of treatment in psychiatry. The latest is transcranial magnetic stimulation, repetitive transcranial magnetic stimulation, which is really very, very effective for the treatment of depression without medicine. So it uses a magnetic intensity of 1 Tesla, like an MRI scan, and you can either stimulate or inhibit neural structures. So for example, a 10 pulse per second intensity, the left prefrontal cortex has profound beneficial effects on depression. And my theory is that Shirodhara is another form of cranial nerve stimulation. When you pour oil, there's trigeminal nerve stimulation, and in a way, you have some cranial nerve stimulation also, I think. So there are a lot of interesting therapies. The future of psychiatric treatment, we are at least 100 years behind from internal medicine, easily, because we don't even have etiological diagnosis. So for the doctors watching this, one thing I want to emphasize is that it is a science, but it's also an art. And we are still many years away from understanding the etiopathology. So when I say depression, we are not saying what is the pathological issue. We are saying that this cluster of symptoms is a disease that can be treated. So we are hoping that, the field is hoping that in the next 15-20 years there will be gene therapy. We may have much more effective treatments, and we hope then that doctors also will feel that this is a robust science.
And how much time it takes to come out of the depression? And how long the medicines are continued? Normally, it's at least for 6 months you give.
Absolutely.
And then you reassess.
Absolutely.
And in how many percentage at the end of 1 year, you may just continue on lifestyle and counseling and your SSRI may come out.
It's highly individual. But I'll say yes, you're absolutely right. 6 months is a minimum period. All the data suggests that under 6 months, SSRIs may not even confer a net benefit. So more than 6 months, we see net benefit in functioning, suicide reduction, etc. Now, after 6 to 9 months, often we try to wean if this is a first episode of depression and if the person is doing relatively well. If the person has a relapse though, then the risk of relapse, subsequent relapse is very high without antidepressant medicine. So many times when we continue the medicine, but I always say the person must do the other things we talked about, yoga, pranayama, meditation and mind. If they get better than that, then we have seen good success in reducing medicine. So
and then another thing is that what about confession? Because if you see that, no, in talking, and second is confession, which can be self-confession, which can be free writing, or which can be writing on a confession website, or which can be talking to anybody. You will confess because normally you are trying to, you are guilt, taking out the guilt out. So are there helplines available where you can talk to them anonymously without disclosing your identity, who can help you in counseling?
Well, there are suicide helplines where trained volunteers will listen in crisis situations. In terms of, there are certain NGOs that are providing psychotherapy services. There are also private organizations that offer online psychotherapy and phone sessions. You're absolutely right, catharsis, the release of repressed emotions, very useful, especially in India. In India, a lot of us, we hold our emotion inside. So journaling, writing, talking, unloading to a non-judgmental person is very useful.
A little bit about suicidal ideation.
Yeah. See, first of all, it's a big issue. As you know, every day you read in the newspaper, 140,000 people kill themselves every year in this country. Many of them are young people under the age of 35. We have the highest suicide rates in the 15 to 29 age group in the world. And in studies in the West, and probably true in India also, they have found that people who have committed suicide, 50% of them visited a GP in 2 to 3 weeks prior to the committing of suicide. Seeking medical help and for physical conditions is much higher in people with depression and suicidality. Therefore, we must screen for suicidality. If anyone talks of suicide, it must be taken seriously.
So medical legal emergency.
It is not, you have to contact family, you have to make sure that some support is given there. We have to take it very seriously. As you said, if someone has ever had a history of suicide attempt, it elevates the risk. Any depression means the risk is higher because about 10.
How will when I talk about suicidal ideation, how will the person come to the doctor? How will the doctor get a clue?
Many times it is just a...
The doctor is not going to ask everybody.
No.
So what do they tell?
One is, if there is that, we talked about the PHQ-2. If PHQ-2 is
But
positive...
then nobody is asking. No? Either I make it compulsory in every patient, you have to fill up this performa outside, they fill it up.
Yes, in the United States today, the United States Preventive Services Task Force has said that every primary care physician, just like they check blood pressure and pulse, must ask about depression. If we have prevalence rates of 35 to 40%,
You must ask. Hello?
we must ask.
बताइए. अभी क्या तकलीफ है? अच्छा ठीक है, मैं अभी थोड़ी देर में बताता हूँ. So you said मैं heart patient हूँ, I'm a heart patient, and is heart patient linked with the depression or anxiety?
So there are two issues in heart.
Here, well, I'll take it the other way around.
Yeah.
I'll take it out. What is reactive versus endogenous depression?
Very
That
good
means
question.
after a heart attack, if a person goes into a depression, is it normal to go?
So until the DSM-3, that's a diagnostic and statistical manual which we base our diagnosis on, they had a distinction between exogenous and endogenous depression, saying that some depression comes without any reason, some happens because of a reason. Subsequent research showed that whether it's because of outside reason or no reason, depression is depression. So today we don't make the distinction between exogenous and endogenous, no matter what the inciting event. If you meet criteria for depression, you have depression. Now, to answer the specific cardiac, there are two issues. One is what we call the Costa syndrome, cardiac neurosis. A lot of people will have chest pain and worries about heart attack because of anxiety issues. That's one, and this person may go to many cardiologists, get angios, multiple investigations, and actually have nothing wrong with the heart. The second thing is depression and stress, of course, can worsen cardiac disease, and post-myocardial infarction mortality is higher among people with depression. Therefore, every cardiologist must be aware of depression as a potent risk for
And
death.
SSRIs are safe in cardiology.
As not just safe, they are probably going to reduce mortality.
Okay.
Yeah. So for two reasons. One is serotonin.
So if a patient goes into a depression after MI, so I don't have to say it is because of MI and
No.
ignore it.
If you see depression, treat it.
Treat it.
If you see anxiety, treat it. Because it's actually so. Heart attack causes fears of mortality. It can cause sexual dysfunction, relationship issues, all kinds of psychological things. And unfortunately, because of the mind-body split, the cardiologist doesn't have the time to explore that and often doesn't think it's important enough. But if depression is as big a risk factor as smoking, then we must pay attention to it.
So we have now short of time. We have
Okay.
only 10 minutes left.
All right.
I'll pick up a few scenarios.
Yes, sir.
Okay. My first scenario is a patient comes with acute anxiety, acute panic reaction. GPs, what to do?
You would want to start on a long-acting benzodiazepine.
So he need to start drugs.
Start with.
Counseling won't work in acute
Not
panic
initially,
reaction.
no.
Not initially.
Not initially.
So he need to start with a long-acting benzodiazepine,
Plus
manage
SSRI.
it, and take help from
And then refer to a counselor and psychologist or
Take help.
psychologist. Yes.
acute anxiety.
Yes.
No panic, acute anxiety.
Acute anxiety, no panic. If it's not too bad, you can either use a short-term benzodiazepine plus an SSRI, plus relaxation techniques, pranayama, mindfulness, meditation.
Acute phobias.
Phobias are a little different. For phobias, often we can use only psychotherapy, exposure. It's called exposure therapy. So if you're afraid of heights or flying, through visualization, we can slowly reduce the panic. Of course, medicine also can help, but that I think I would suggest phobia should be referred actually to a psychologist.
Anxiety and underlying depression.
Anxiety, depression, use an SSRI. As we said, if it's mild, use lifestyle psychotherapy. Moderate, use SSRI, which treats both anxiety as well as depression.
Then we come back to depression with underlying comorbid conditions like heart attack, blood pressure, diabetes.
Treatment's pretty much the same because SSRIs are like the newer SSRIs don't have much drug interactions. Obviously, keep an eye if you have a cardiac patient on warfarin. SSRIs can increase the clotting, the INR, so you want to check the dose. But otherwise, you would manage pretty much as if there was no comorbidity.
Depression with sexual dysfunction, erectile dysfunctions.
That is a difficult topic because, as you know, SSRIs will cause sexual dysfunction in up to 30, maybe 40% of cases, including erectile dysfunction. Sometimes, however, erectile dysfunction, so first is rule out an organic cause for the erectile dysfunction and the sexual dysfunction. If that is ruled out, then there are two possibilities. One is depression itself causing erectile dysfunction, decreased libido, in which case using SSRI will actually increase libido. So first is a therapeutic trial of SSRI, but explain to the patient that SSRI itself we have to decline cause. Reassess in 4 weeks. If the person doesn't have anxiety, you can use something called bupropion, which is not a SSRI. It works on dopaminergic as norepinephrine neurotransmitters, does not have sexual dysfunction, in fact increases libido. Another is to use a combination of bupropion with SSRI. But usually this is a bit more special. I think specialist care is required for sexual dysfunction.
What about performance anxiety?
In terms of just exam and so on?
Everything. Sexual, non-sexual.
Well, you can use beta blocker. You can use a short-acting beta blocker if it is specific like public speaking. You can try some propranolol, even metoprolol, cardio-specific is fine. You can use cognitive behavioral therapy. CBT is also useful. Usually for specific performance anxiety, I would not recommend a daily medicine.
So how can, the last couple of things is when we talk about, tell us something more about your Live Love Laugh Foundation.
Oh yeah, absolutely. So
And how are you connected to Deepika?
Okay. So the Live Love Laugh Foundation was founded October of last year and started by Deepika Padukone after she went through depression and recovered from it, and in that process she became very aware of how important and how common this condition is, and she also realized that there's so much stigma and shame in this country, and I think she had the courage to speak out publicly about it, which is remarkable because that changed the national conversation. Ever since, I think we are talking more about depression. So the foundation was started with the intention of decreasing stigma, increasing awareness about all mental health, specifically depression initially. And so we are looking at increasing awareness so that every member of the public, especially, and doctors and policymakers are more aware of this condition. We're also trying to, with the help of partners like you, help doctors understand more about depression. And we want to look at the standardization of psychotherapy as well. So it's
how can the Live Love Laugh Foundation, Indian Medical Association, and Heart Care Foundation of India work together?
I think pretty much. I mean, this is a good beginning where clearly the Indian Medical Association, the Heart Care Foundation has done years of work and has earned rightfully so the trust of many doctors as thought leaders in the field. And we want to partner with you in reaching out to the doctors community in helping them become more aware so that we can all be part of the solution. Because we realize that, look, this is a national problem. We need the participation of every enlightened member of the society, especially doctors and policymakers. So I think that's how we can work together to reach out to more.
So we can work together and we need your help. All the doctors in the community, all the doctors in the profession and the public who is listening to this program, we need doctors to be more sensitized. In any way, Medical Council of India has come out with the requirement of 10% CME has to be devoted to mental health. Unfortunately, when we did our MBBS, mental health was not taught to us. Spiritual health was not covered at all.
Sure.
Social health was not taught to us. It was limited only to a PSM level, PSM chapter. So therefore, we need to indulge ourselves and we need to convert it into practice. It is important. We need to have a counselor. I always say for a GP, hire a dietitian, hire a pharmacist and hire a counselor as a full time with you. They become your partner. You will earn more. You will be able to do justice with the people. That's all for today. We thank Dr. Shyam Bhat to be here with us. And through him, we also thank our cine star Deepika ji, who has tweeted about that yesterday and who has also given a statement for the press on this particular aspect of an association of Indian Medical Association with the Live Love Laugh Foundation. And me, Dr. K.K. Agarwal, I'll be say goodbye to you. We'll come back next week. We also thank Librate, our digital partner, eMedinexus, our webcast partner, Talking Point Communication, who was the event manager for this particular show, and Indian Medical Association, Heart Care Foundation of India. I say goodbye to you. We'll come back next week with some other topic. Till that, goodbye. Thank you.